Presentation. Hello, everyone. First of all, thank you, Dr. Claudio Dufour, for the invitation me to AATM Cellular Therapy webinar. Now, let me introduce my colleague, Dr. Koray Yalçın. We are working together Mesenchymal stem cell project. So maybe he will help me in the question session. So, introduce.
Hello to everyone. I'm Dr. Koray Yalçın. I am the one of the authors of the Mesenchymal stem cells.
Good morning. Nice to meet you.
Thank you. Me too. I'm studying on bone marrow transplantation, pediatric bone marrow transplantation, and cellular therapies with Professor Ercüment Ovalı. And I'm now here for the presentation and the question part.
Okay. Oh, there's a problem.
There's a share screen button.
Oh, I can't find the share screen. But there's a problem. Yes. Yes. In this webinar, I will talk about the possible role of mesenchymal stem cells in COVID-19 induced ARDC treatment. The novel coronavirus disease 2019 was first detected in Wuhan, China in December 2019. Since then, COVID-19 spread like wildfire over the world, and who just redescribed it's a pandemic. Today, more than 10 million people have been infected with the COVID-19 and around 500,000 patients have died. Main cause of this in COVID-19 infection is ARDC. Several therapies such as antiviral, antimalarial, antiparasitic drugs, anticytokines, and conventional plasma transfusion are under the investigation. But it is still difficult to say that COVID-19 has a standard treatment. COVID-19 infection can monocyte and macrophage system is at the center of the pathogenesis. Cytokine storm is associated with the severity of the disease. We have three options for the treatment: good supportive care and effective antiviral therapy and cytokine treatment. We have three anti-cytokine therapies at now. Cytokine antagonists as IL-1, IL-6 blocker or TNF blockers. We can use steroids, non-steroidal anti-inflammatory disease drugs, and mesenchymal stem cells. MSC appeared to be one of the most ideal agents of anti-cytokine therapy. Now, I will discuss why this is so. Mesenchymal stem cells can be produced different sources. There is no clinical study showing which mesenchymal stem cells from different sources are more effective. However, some comparative preclinical studies suggest that fetal originated mesenchymal stem cells may be more effective than the others. Mesenchymal stem cells have immunomodulatory and anti-inflammatory effects and also can detect injury in microenvironments and directly responses for trigger the regeneration process. Mesenchymal stem cells can control M1 M2 balance. As you know, monocyte macrophage system can be divided into major subgroups. M1 macrophages have antimicrobial properties, M2 macrophages have tissue repair capacity. Recently, first clinical autopsy data in macaques showed that severity of SARS-CoV is related to M1, M2 imbalance. MSC can turn the imbalance into the balance because MSC can convert M1 to M2. Also, mesenchymal stem cells can reduce alveolar cell apoptosis by secretion, keratinocyte growth factor, angiopoietin-1, hepatocyte growth factor, insulin-like growth factor, etc. They can decrease pro-inflammatory substance. They can secrete immunoregulatory substance as IL-10, TGF-beta, indolamin deoxygenase, prostaglandin E2, etc. They can control superinfections by secretion beta-deficit hepcidin, hypokalin 2, or small interfering DNA. Also, they can regenerate alveolar cells directly or indirectly. They can improve alveolar fluid clearance. Also, they can attenuate end-organ dysfunction. With all these abilities, based on the current clinical trials, mesenchymal stem cell therapy appears safe. Hence, mesenchymal stem cell may be one of the most ideal anti-cytokine treatment agents. Although mesenchymal stem cells have a very safe profile, there is a clinical report in the literature that they may cause pulmonary embolism. It's an important side effect. It indicates that we have to be careful in the use of mesenchymal stem cells in COVID-19 infection, in which hypercoagulability is a real problem. To date, 22 clinical trials assessing the safety and efficacy of mesenchymal stem cell therapy in ARDC patients, of which 10 is about COVID-19 related have been registered in the clinical trials.gov. MSC doses used in COVID-19 ARDC studies are designed as 1 to 10 million cells per kilogram, single or two doses. Although mostly mesenchymal stem cells originate from umbilical cord are used, we see that they are used fat or bone marrow origin cells in studies. In these studies, mesenchymal stem cells were suspended in saline or saline containing 1% albumin, and high molecular weight heparin was also added the final product in only one study. To date, three clinical trials have been completed. First study is placebo-controlled clinical trial, in which ARDC patients received an intravenous injection of allogeneic adipose-derived mesenchymal stem cells, 1 million per kilogram. Mesenchymal stem cells seem to be safe and well tolerated in the patients. The two groups showed no significant difference in the length of hospital day, ventilator-free days, or ICU-free days within 4 weeks after treatment. Second study is a phase 2 clinical trial, in which patients received a high dose level of allogeneic bone marrow mesenchymal stem cells, 10 million cells per kilogram. MSCs seem to be safe and effective. Third study is a placebo-controlled clinical trial, in which transplantation of menstrual blood-derived mesenchymal stem cells could reduce the mortality in patients influenza virus-induced ARDC without adverse effects after 5 years follow-up period. Recently, one published study involved 7 COVID-19 patients in the MSC-treated group and 3 patients in the control group. In the MSC-treated group, patients received 1 dose mesenchymal stem cell injection at 1 million cells per kilogram of weight. No serious adverse side effects were observed in the MSC-treated group. All the 7 patients in the MSC-treated group recovered. A few days after MSC transplantation, oxygen saturation were increased, and biomarkers for inflammation were decreased, and peripheral lymphocytes were increased. Now, I will talk about our study. 7 patients were analyzed in this preliminary report. Diagnosed COVID-19 with specific PCR test and clinical radiological findings. The patients who needed mechanical ventilation, despite of standard therapy, were involved in this study. The patients received mesenchymal stem cell as a salvage therapy in addition to standard therapy recommended by Turkish Ministry of Health. The patients who had cellular therapy in last 3 months and had embolism in medical history were excluded. You can see the treatment schema of COVID-19, which is recommended of Turkish Ministry of Health. According to these recommendations, primary step begins with hydroxychloroquine. Antiviral treatment is recommended in case of disease progression. CGM GMP grade umbilical cord derived mesenchymal stem cells were used. Totally, 1 million mesenchymal stem cell per kilogram was administered by combined routes. In intravenous route, we infused 700,000 MSC per kilogram in 100 ml saline containing 4,000 international unit high molecular weight heparin. In intratracheal route, we injected 300,000 MSC per kilogram in 10 ml saline. One administration for each patient are used. In this table, you can see that youngest patient is 49 and the oldest one is 73 years old. And all patients are PCR positive and they are critically ill. Interval between intubation and mesenchymal stem cell therapy is 1 to 9 days. After the treatment, values of inflammatory biomarkers, CRP, of patients decreases significantly. Other inflammatory biomarker procalcitonin decreased for 6 of 7 patients, stable only for 1. The outcomes of mechanical ventilation parameters varied, like the PO2 and PO2 ratio ranged from 93 to 301 before MSC therapy and improved for 5 of 7 patients within 8 days after therapy. Overall range was between 172 to 370. The external PEEP ranged from 12 to 16 centimeter water pressure before MSC therapy and improved for 5 of 7 patients within 8 days after therapy. Lymphopenia was present for all patients. 4 patient lymphocyte counts increased with mesenchymal stem cell therapy, but in 1 patient decreased and in 1 patient stable. In chest radiographs, significant improvement was detected in all patients after MSC infusion for shortest 5 days, and the longest 11 days. No side effects related to MSC use were observed at the end of the study. As the conclusion, at the time of publication, 4 of 7 patients were weaned. Not all the patients are discharged. By controlling the hyperactive immune system and reversing the destructive effects of ARDC, mesenchymal stem cell could have a promising efficacy for critically ill patients in the advanced phase of COVID-19. If our results can be confirmed, we may achieve the anticytokine treatment with the least side effects. Controlled trials with more patients are needed to assess efficacy and safety of mesenchymal stem cell in COVID-19. I will talk about our observations from ongoing studies and lessons to be taken from previous clinical studies. First one is, patients with higher inflammatory markers may have a better response. If mesenchymal stem cell infusion can be done early, the better results can be achieved. In some patients who don't respond to the first infusion, the second infusion may increase efficacy. Another thing is the cell quality. The cell quality of mesenchymal stem cells can affect the clinical results. European trials for graft-versus-host disease show that immunoregulatory properties of early passage mesenchymal stem cells are effective enough to make a significant difference in the clinic. Another observation, immunoregulatory abilities of frozen mesenchymal stem cells may be impaired to affect the clinical response. Frozen mesenchymal stem cells need to be recultured for at least 3 days before they can acquire lymphocyte inhibition abilities before freezing. Therefore, quality of mesenchymal stem cells, correct therapy timing, and correct dosing and route will be important in mesenchymal stem cell treatments. As a final decision, although mesenchymal stem cells seems to be effective and safe in the treatment of COVID-19 ARDC, the results of ongoing clinical trials should be seen for the right decision. Thanks for your attention.